For the next 3 hours, 3.5 hours, you're going to get to hear about what I think is the coolest part of medicine, hematology, oncology. It is a privilege to get to do this. So, I'm going to do my very best to help you knock this out of the park. All right. So, let's go ahead and get started. Okay. We're going to start this morning with hematology. And I titled my talk, subtitled it out. It had to have something silly at this hour in the morning, red, white, and bruised. And it's because we're going to talk about red cells, white cells, platelets, and coagulation. My goal is to cover the hematology content areas. Your objective, and you may think, what kind of crazy objective is this, is to identify diamonds from dung for each of the content areas. So what do I mean by that? What I mean by that is that I think identifying diamonds from dung is both a study skill and a test-taking skill. So what are you guys in the midst of doing right now? You're in the midst of sifting through a whole lot of material, a whole lot of dung, for lack of a better word. And what you're trying to do is identify what those really high-yield topics are. Not necessarily the most clinically important topics, right? But the diamonds, the high yield, the areas that are going to show up on an examination that you're going to knock out of the park. So your preparation is involved in trying to find those diamonds in the dung. And then it really goes, the same thing comes down to test day as well. And how are these questions written? They're written with lots of long stems and sometimes with a few red herrings in those stems. So you got a long stem that can maybe be filled with a lot of dung. And what you've got to do is read that stem and identify the piece of information that's a diamond that's going to help you answer that question. So I'm hoping that my talk will help you in the process of sorting diamonds from dung, and that we'll do that in each of the content areas, the red cells, the white cells, the platelets, and coagulation. Okay. When we talk about red cell disorders, that'll be the first part of my talk. We're going to talk about production problems and then destruction problems. White cell disorders is going to be a lot of pictures. I'm going to enjoy showing that with you guys. We're then going to talk about bleeding and clotting disorders. And I'm going to say right now, I'm going to make a very embarrassing confession that I've been a hematologist, oncologist for, I started training in 2003, four, and finished fellowship in 7, yeah. And so I've done it a while, but I have to say that I think this is like the first year I've ever felt like I really understood the coagulation cascade. I think it is the most, I think when it's taught to you and laid out for you, it is just sometimes a jumble of numbers and Roman numerals, but we're going to make sense of it today, okay? And we're going to make sense of it in a way that's going to help you answer questions. We're also going to talk a little bit about just some special issues in infants that may overlap with some of the content in neonatology, but it'll reinforce some important topics. Red cell disorders. When I see a patient, this is really how I break it down for them. I tell them when I'm working you up and I'm evaluating your anemia, I think about it as there are only 2 causes for anemia. You're either not making or you're doing too much breaking. And I like that paradigm because I think it really helps me think about, what the patient's problem might be. Helps me characterize it, helps me come to a diagnosis and develop an appropriate management plan. So, what do I mean by that? So what are the making problems or the production problems? Well, making problems can be divided into 3 categories. Deficiencies. You don't have enough iron, you don't have enough B12, you don't have enough folate. It can also be defined as infiltration problems, like leukemia or lymphoma taking over the bone marrow, or just plain bone marrow failure problems. Another way of thinking about it, and I like to do this again, I think one of the most important jobs we have as pediatricians is to be teachers. My focus today is clearly on your board preparation, but I'd like to share with you just kind of some of the little things I like to do when I teach families about a diagnosis. I'll say that it's a production problem, and what we have is a factory your bone marrow, that's supposed to be making red blood cells, and that factory can have a couple different problems. You can either have a raw material shortage, or maybe you can just have problems with your machinery, okay? Or your workers being on strike, or whatever silly phrase enters my head at that time. But again, for the sake of things here today and for taking care of patients and taking care of exam questions, I think it is very valuable to break anemia down into production and destruction. Destruction can be subdivided into bad hemoglobin. Maybe that's a little pejorative, forgive me, but I don't want to pick on anybody's hemoglobin. But let's call that either deficiencies in particular proteins or mutated proteins, membrane defects, which are fascinating, enzyme deficiencies, or a destruction problem caused by something outside the red blood cell. So the first three are inside the red blood cell, but we can also have destruction problems outside the red blood cell as well. Obviously, this is another way that we characterize anemia is something that you've learned right away in medical schools, that you want to do it via the cell size. And that's clearly very helpful. We define anemia as being micro, macro, or normocytic, small, big, or normal-sized cells. The classic that we see most often in pediatrics is microcytic anemia. You guys know that. And microcytic anemia, for me, is really typically two things. It's either iron deficiency anemia or thalassemia. Yeah, sometimes anemia of chronic disease can be normocytic or it can be microcytic, but it can also be normocytic. And I think it's much less common in children and, is often kind of, unless you have someone with a rheumatologic or immunologic disorder, kind of a soft call diagnosis or a diagnosis of last resort. Macrocytic anemias show up typically in one of three ways, from either B12 deficiency, folate deficiency, or often as a side effect from medications. Just telling you for what I see in referrals, I probably see 30 to 50 microcytic anemias to every, maybe more, to every macrocytic anemia that I've ever been asked to evaluate. Okay, so let's get started with some questions. We'll use the questions to kind of introduce an area, and then we'll flesh out that area a little bit more. So you are seeing a 2-year-old girl for the first time. On history, you discover she's drinking 36 ounces of milk per day. You order a CBC. So which of these is likely going to be true? Is her hemoglobin going to be 11.8, her red cells 5.34 times 10 to the 9, her MCV 56, her reticulocyte count 7.5%, or her RDW 12%? Fantastic. This is what's most likely is, you guys know by history and you've seen in your clinical experience that the classic story of iron deficiency anemia is the milk drinker. And that little milk drinker is going to have a microcytic anemia. Okay. The other purpose of each of those answers is to help familiarize you a little bit with what else you're going to see in a CBC. So if you're drinking 36 ounces of milk, well, the first answer, you're probably going to not have a normal hemoglobin, right? I mean, that's the classic story. You're filling up on milk, you're not getting other you're not getting iron-containing foods in your diet, and you're getting a little bit of microscopic GI bleeding from all that milk. The RBC number here is, even without reference ranges, you need to recognize that an RBC number greater than 5 is normal, okay? You know, and less likely to be something that you would see in iron deficiency anemia. Yeah, you can see a normal RBC number in iron deficiency anemia, but you're not going to see an RBC number greater than 5. You might even see one as low as 2 or as low as 1 if the iron deficiency anemia is bad. Okay, MCV, remember this is classic. You're going to see an MCV that is very small. Okay, reticulocytes, again, you know, what are reticulocytes? They're young red blood cells. And if you're making to be making young red blood cells, what has to be going on? The factory has to be working, okay? So you're never going to see an elevated reticulocyte count in iron deficiency anemia. I've put it in here as a relative retic. The best way to look at that retic is actually with the absolute reticulocyte count, but we'll talk about that a little bit later. RDW is a sometimes challenging but also very underappreciated red cell indices. What RDW does is it describes the red cell distribution width. If you were to take the red cells and create what's called a bin plot, where on the vertical axis you have the number of cells, and on the horizontal axis you have the bins for different red cell sizes, you would find in iron deficiency anemia that the spread of red cells, the different sizes that are being made in the bone marrow is really quite large. Why is that? Well, the factory doesn't have enough raw materials, and it's doing a lousy job making its product. And so some of those products are going to be really small, and there isn't going to be quality control that each product gets made the same way. So the red cells are small, they have a wide variation in size, and they also have a wide variation in shape. Variations in shape and size, anisocytosis and poikilocytosis. Okay. On routine examination, a 1-year-old boy is noted to be pale. He is in the 75th percentile for weight and 25th percentile for height. His exam is otherwise normal. Hemoglobin is 7.4, white count of 7,000, platelets of 750,000, reticulocyte count 0.5%, sickle cell testing, stool guaiac negative, and MCV 65. So what is your next step going to be? Good. What we're going to do is we're going to start iron sulfate. I think next year I'm going to make this question even a little more challenging and try to trick a few more of you into the idea of a blood transfusion. You know, really the teaching that we're doing now is that, and really unless you're symptomatic, we can let these kids, you know, go home and get started on oral iron sulfate for a pretty darn low hemoglobin. You know, just yesterday in clinic, I sent somebody home to start their ferrous sulfate with a hemoglobin of 5.3, and you know, I went through it with the family. I said, you know, look, what was your child doing this morning before they came to see me? And the answer was they were running around playing. And you know, unless you know that child has maybe, you know, not thriving, you know, you're uncomfortable with the tachycardia, you're hearing an S3, you know, just something's bothering you that really makes you feel that they're symptomatic. You know, this is definitely something that can be managed with oral therapy and outpatient follow-up. Okay. So iron deficiency anemia. You know, we've used those couple questions, and let's use them to tease out some good teaching points. And just like we talked about anemia as being a problem of either not enough making or too much breaking, you can think of iron deficiency anemia as being you're either not getting enough in or you're losing it, okay? So every cause of iron deficiency anemia is either going to be dietary, you're filling up on low iron foods, or it's going to be a blood loss problem, or it's going to be a combination of the two. You know, and blood loss, the most common problem is probably irritation by cow's milk protein. Sometimes you need to think about things like a Meckel's, ulcers, or a whole slew of other things. Probably the most challenging patients with iron deficiency anemia are ones who don't fit our classic milk drinker story, and those are kids who may have some type of absorption problem, and that can be from lead poisoning, celiac disease, inflammatory bowel disease, and their treatment can be a little bit different. But they're going to also show up with some other symptoms, abdominal pain, malnutrition, that I think may get you thinking a little differently about them. When somebody has iron deficiency anemia, you're going to see certain clinical features. You really can see the classic pica. It can be eating dirt, it can be eating ice, it can be, paper, other great nutritious foods, these children, it's interesting because it's a chronic problem. Just like the little boy I saw yesterday who I sent home, one of the things that comforted me was also knowing in my mind that this didn't happen to him yesterday, so I don't need to fix it the same day. It just kind of sneaks up on the family that, oh my gosh, their child is really pale or sometimes has a little bit of a yellowish hue. They can have tachycardia, they can have a murmur. Chronically, the reason that we want to try to treat this is that not having iron is basically not a good thing for the brain. And children who are chronically have chronic iron deficiency don't do as well in school. And if you're having problems getting a family to kind of get with the program, for lack of a better term, I think that's the teaching point that can often bring that home. So we went over this a little bit with the numbers I showed you, but in iron deficiency anemia, you're going to see microcytosis. The more profound the iron deficiency anemia, the lower the more microcytic you're going to be. The RDW, that distribution, that quality control and production of the red cells in the marrow is not going to be very good. It's going to be making a lot of red cells of a lot of different sizes. The cells are going to have different sizes and they're going to have different shapes. An IDA smear is fascinating. It just looks wacky. You can have a normal relative reticulocyte count. More often, it's going to be low, and even most importantly, if you're looking at relative reticulocyte count, it's going to be inappropriate, right? It's not going to be revved up like you would expect it to be in anemia. And the most important thing is actually to look at the absolute reticulocyte count, not the percentage. The RBC number is usually low. This can trick you though sometimes. Sometimes it can still be normal. My little guy yesterday still had a normal RBC, but his ferritin was 1, okay? So I don't know what your institutional norms are, but I don't think anybody's institutional norms make a ferritin of 1 normal. And interestingly, just something, I put it in the question previously that you can see with iron deficiency anemia is thrombocytosis. The patient that I used in example 2, I think we said had 750,000 platelets. Sometimes it can be over 1 million. Do you need to treat that? No, okay? They're not, they are at a little bit of a risk of thrombosis. And you can see, if you do this long enough, you'll see a child, who has iron deficiency anemia end up with a cerebral sinus thrombosis. But when you see them, there's really not indication or evidence-based literature to support using, an aspirin or any other kind of antiplatelet drug. But generally, the thrombocytosis is not an issue, and it's going to go away when you correct the iron deficiency anemia. How do you manage this? You guys know this. It's gonna basically tell you that oral iron's the way to do this, and that you have to identify and correct the cause. Limit milk to less than 16 ounces. Sometimes Depending when I want to make a point of emphasis, I'll tell families I really want to limit this to less than 8 ounces a day just to keep them from cheating. We don't transfuse, really only for severe anemia with where you're worried about cardiac failure. I think the lowest number I've seen on an iron deficiency hemoglobin is 1.8. But, and yes, we did transfuse that patient. And we transfused them very slowly because remember, they got to that level of anemia over a long period of time, and you need to correct it slowly. Give small aliquots of blood over 3 to 4 hours to let the body adjust to its new being. You can do intravenous iron. The patient population that this is most appropriate in are those patients with absorption issues. We do this a lot with our inflammatory bowel disease patients. We give them intravenous iron. So what I want to emphasize, and I'll move the mouse over here just to show you, is that this number is an RBC number. And so what I want you to understand is that the absolute reticulocyte count is the reticulocyte percentage expressed as a fraction times the RBC number expressed in millions. Okay, so again, it's going to be very important for you. And the interpretation is that anemia with an ARC that's less than normal is a very poor response by the bone marrow to the anemia, and it demonstrates decreased production. Anemia with an ARC in the normal range, well, that's not right either, because that means it's an inappropriately low response, and again, probably represents decreased production. Anemia with an ARC that is greater than normal represents an appropriate response, and red cell destruction is likely causing the anemia. Okay, so this is iron. No wait. Let me just go forward. Okay, this is the classic picture of iron deficiency anemia, and what I want you to appreciate by this is how all these classic features are present on the cell. Okay, what you have are, you've got all kinds of variation in size, you've got all kinds of variation in shape, you've got a lot of central pallor, right? Okay, and a little harder to appreciate because we don't have a normal lymphocyte in the field, but these cells are small. What you can also notice is that there are a lot of platelets hanging out in the background. And again, that goes to the point that often with anemia we can see with iron deficiency anemia, we can see thrombocytosis. Empiric treatment involves oral elemental iron, 3 to 6 milligrams per kilogram per day. When you retest, the classic teaching is, get them started, do it in 4 weeks. I'm going to bring my young man back from yesterday a little bit before that. I just want to, do a compliance check. And I'm going to expect them, by 4 weeks, you better be at least up a gram, more likely to be up more than a gram. And what you typically see for every gram increase is a 3% rise in hematocrit. You're going to continue therapy after you make that check and that you decide that they're headed in the right direction. You're going to continue that therapy for 2 more months and then recheck. You're going to discontinue if normal. And I think what I want to emphasize here is what the time you want to discontinue for normal, and this is a good practice question and a good board question, is you're going to continue until the ferritin is normal. Because what's the last thing to correct? The ferritin, okay? All right. How do we, the best thing isn't to treat iron deficiency, it's to prevent iron deficiency. And the way we can do that is by encouraging breastfeeding, by starting iron supplementation for those infants who are exclusively breastfed beyond 4 months of age, starting more vulnerable populations like preemies a little bit earlier, and making sure our patients who are not breastfed are on an iron supplemented formula during the first year of life. When we start introducing foods, it's important that we introduced iron-enriched cereals early on, and we need to make sure our families are avoiding cow's milk during that first year of life. And then once we make that transition beyond the first year of life, our teaching has to be like, hey, maybe the milk industry and their got milk ads, maybe that isn't really the, maybe that's a scam. Can I say that? But think about it. How many other mammals drink milk beyond the first year of life? A friend of mine pointed that out to me, who is with a wildlife biology background, and I was like, that's a good point. So again, I think what we want to do is we want to avoid cow's milk during the first year of life, and then beyond the first year of life, it's very important that we do appropriate teaching about limiting it and also encouraging other foods as well. Just a word on iron deficiency anemia and lead poisoning. Remember that pica is a symptom of iron deficiency anemia. It's not a cause. Pica involves eating clay, other non-nutritional substances. I think ice kind of falls in there as kind of a soft call. People can eat ice for a lot of reasons, but it is something on history that I pay attention to. Pica is the link between iron deficiency anemia and lead poisoning, and iron deficiency anemia actually increases the absorption of lead. So, you're very likely to see these in a common setting. It's always interesting to me to just ask, those of you who are in practice and those of you who are just coming out of residency, who have been in practice or are just coming out of residency, how much lead poisoning you've seen. So just for my own education, if I can, how many of you have treated lead poisoning, during your careers or on a regular basis? It's interesting because I'm a Texan by way of my medical education and training. I was a Baylor College of Medicine guy for school, residency, and fellowship. And in Texas, nothing's old enough. We just don't see a lot of lead poisoning. You get a little bit from lead-lined lead clay pots and things like that, or certain glazes that might have lead involved in them. But I've, in my career, have really seen very little lead. With lead poisoning, some of the things that we can see is this coarse basophilic stippling in red blood cells. This is something that I think is important to kind of tuck away and be able to remember for a board question. This is one of the images that I think is important for you to be familiar with. Okay. All right. 15-year-old African-American male presents to your office as a new patient. All through his life, he's been getting iron supplementation for microcytic anemia. He's got a mom who's a meticulous record keeper. I think she's an engineer. She hands you a sheet of lab results with the following information. And she also recalls, again, because of her meticulous record keeping, that her son's newborn screening had an unusual result, and she recalls that he was positive, or that he had presence of hemoglobin Barts. So what is the best explanation of these findings? Okay. Okay. Fantastic. So what we're going to do is we're going to spend a good bit of time talking about thalassemia and iron deficiency anemia. And I think this is the critical, both for practice and for test taking, the critical piece of knowledge to understand in evaluating microcytic anemia. So let's just remind ourselves what hemoglobin is, okay? Again, this is embarrassingly something that really didn't all click into place for me until a little bit later in my career than I'd like to admit. But I think once you remind yourself of all that material that was just thrown at you, like drinking from a fire hose in medical school and training, once you can kind of like catch a breath and sort it all out, it really helps you be a better doctor. So what we want to remember is that hemoglobin is a tetramer. It's made of 4 globin chains, okay? And that we have various hemoglobins, and they all get their names. They get different names based on the combination of globin chains that make up the tetramer. So the most common hemoglobin, or normal adult hemoglobin, is hemoglobin A. And that consists of 2 alpha chains and 2 beta chains. So we write it as alpha 2, beta 2. Fetal hemoglobin, the most important, most common hemoglobin in utero, is alpha 2, gamma 2. Okay? Hemoglobin A2 is a minor hemoglobin, depending on who you are, somewhere present in the 1 to 2.5% range. And that is made up of alpha and delta chains and is known as alpha 2, delta 2. A hemoglobinopathy, or a problem with your hemoglobin inside the red cell, can result from either mutations in the globin chain or decreased, or point mutations in the globin chain, leading to a globin chain that is kind of different than normal, sickle cell, or it can be a mutation in a gene leading to a mutation in the gene for one of these chains, leading to a decreased production, and that's the thalassemias. So thalassemias are inherited disorders of globin chain synthesis. And so the problem gets down to is things are out of whack. We need things, our whole body is about being in balance, right? And in thalassemias, we're out of balance. Our numbers of alphas and our numbers of betas don't match. And that causes a problem, okay? And again, to understand this, I think really to understand it and be a better clinical doctor, you have to take the minute and read and remember the little bit of basic science. So globin chain synthesis is a little more challenging. You have 2 alleles on each chromosome 16 that are responsible for alpha globin chain synthesis. So you got 4 genes, 1, 2, 1, 2, that control your alpha globin chains. Beta globin chain is a little bit easier. It's 1 allele on each chromosome 11. So let's talk about beta thalassemia a little bit first, because that's a little easier. We only have 2 genes to deal with. We only have 2 copies to deal with, not 4. Okay. So beta thalassemia minor are heterozygotes that have 1 normal allele and 1 thalassemic allele. They can have mild or no anemia. Typically, I would say they tend more often than not to have anemia, and with a disproportionate microcytosis. What the heck does that mean? That means that this is going to be a patient who is anemic, but wow, they have a microcytosis of 50 or of 60, and they might just be a little bit anemic. I think my example, I make them a little more anemic, but again, what you want to think about with beta thalassemia is that these patients are definitely going to be microcytic, and not just a little bit of microcytic like in the 70s. They're going to be in the 60s or in the 50s. Beta thalassemia major is if you don't have any globin gene production, and this is a horrible condition. And these are infants who have pallor, irritability, growth retardation, hepatosplenomegaly because they're doing extramedullary hematopoiesis, making red cells in places that they're not supposed to. Their marrow is trying to work like crazy, so they get expansion of the bone marrow space and facial bones, and this leads to that characteristic chipmunk facies. In the hemoglobin electrophoresis is going to be almost all hemoglobin F, and these children are going to be transfusion dependent, and once you're transfusion dependent, you have a risk of iron overload, and that's a bad thing. Okay. Beta thalassemia intermedia is that you have some normal globin chain production, and that might be one mutation that eliminates production, and another mutation where you're getting a little bit of production of beta globin genes. These patients usually not require transfusions, and you're going to also see an increase of A2 and hemoglobin F in these patients. Okay. Alpha thalassemia. So we got 4 genes, and your patient's got four gene loci, and so we're going to have 4 things to talk about. We can talk about alpha thalassemia trait. Sometimes these patients are called silent carriers. These patients are essentially asymptomatic and almost impossible to find, in the sense that they typically don't have any hematologic abnormalities. They might have a mild microcytosis, like a number in the 70s. Alpha thalassemia minor and is 2 loci affected, and I kind of always like to teach this a little way to kind of torture you, so forgive me, okay? I want to torture you for a moment. How do I want to torture you? I want to make you think about organic chemistry, okay? At least this is how I thought about it. I actually liked organic chemistry, but I'm weird. You guys have already figured that out. But remember, we got 4 genes, 2 on this side, 2 on this side, right? Okay. If the 2 loci that are affected are on the same side, it's called cis. Remember, just like naming structures around a double bond in organic chemistry. Anybody getting flashbacks, nightmares, anything like that? Okay. If the affected loci are on opposite chromosomes, right, like opposite sides of the double bond, I know, I'm a nerd, okay, and I know, this early in the morning, you got to deal with a nerd. Hang in there, okay. That's called trans. And like, why am I even taking the time to point this out? I'm not just tormenting you, right? Because let's think about it. If you're cis versus trans, it means a lot in terms of genetic counseling, right? Okay? Because if you're cis, you got 2 out here, and you have children with someone who is also cis, or even just a silent carrier with the trait, you can have a child who has 3 genes affected or 4 genes affected. Whereas if you're just trans, the most number of genes that could be affected would be 3, right? So it is important to know, and it's interesting. It's also interesting to know that the patients who have cis tend to be from Asia, and African Americans tend to be trans. Again, just important for thinking about genetic counseling. So 1 gene affected, two loci affected. Patients are generally asymptomatic, very mild anemia, low MCV. You see these patients, you turn them free for the rest of their life. Make sure they know that you don't want folks giving them iron, and just make them aware that there may be reproductive issues to think of down the line. Hemoglobin H disease is 3 loci affected, and so what's going to show up on that is that you might end up with getting some beta-4 tetramers, right? Because you have unbalanced production, and the betas don't have enough alphas to match up with. This is a disease that can have moderate to severe hemolysis. Again, this is a destruction problem from not having, the quite right hemoglobin. molecules. And again, if you end up with all 4 loci affected, this ends up with hydrops fatalis and death in utero. Patients with alpha thalassemia often have hemoglobin BARTs or gamma 4 on their newborn screen. Why is that? Remember, making hemoglobin in a perfect bone marrow factory is about keeping the balance, right? And so in utero, you're balancing alphas and gammas to make hemoglobin F. But if you don't have enough alphas to match up with all your gammas, maybe those gammas are going to decide, heck, we don't need the alphas, we're just going to make a tetramer among ourselves. And that's hemoglobin BARTs, and that'll show up on the newborn screen, okay? Why won't it show up later in life? You're not making enough, your production switches from gamma chains to beta chains, okay? But on the newborn screen, you can see a little bit of hemoglobin BARTs, okay? Alpha and beta thalassemia. So they're both going to have low MCV. They can have normal or increased RBC numbers. This is the case where we have where I work. I'm blessed to work with some really wonderful folks, and including in those folks are the technicians in our laboratory, in the hematology, in the cancer hospital where our clinic is. We just have phenomenal technicians, and we'll send up a CBC, and they'll make a diagnosis of thalassemia for me sometimes as they pull the CBC off the machine, and they'll say, "Oh, little anemia, RBC number of 5.4. It's got thalassemia, right?" And I'm like, "Yeah, you're absolutely right." So low MCV with an increased RBC number, an RBC number that is above normal, better clue you into a thalassemia. The RDW tends to be normal. It can be mildly increased. The typical range for an RDW is 12 to 15. If you see a 16, this could still be thalassemia. If you see a 22 or a 23, like on my little boy yesterday, that's a factory that's doing a terrible job of making red cells, and that's going to be a factory that has a raw material problem like iron. Beta thalassemia, you don't have enough beta chains, so your delta chain production is going to peak up a little bit, and you're going to have an increase in hemoglobin A2. Alpha thalassemia, conversely, like we talked about, you're going to have that gamma 4 tetramer early on in life. But basically, your electrophoresis is going to be normal after the newborn period. So alpha thalassemia ends up being, when you're diagnosing it in someone later in life, really kind of a diagnosis of exclusion unless you choose to do some genetic testing. Okay. Routine CBC, 1-year-old, hemoglobin is 7.4, a mildish anemia for a 1-year-old, MCV of 664. Follow-up hemoglobin electrophoresis demonstrates an increased concentration of hemoglobin A2. So we just covered this. What's that going to be? Okay. There's nothing that gives you an increased hemoglobin A2 other than beta thalassemia. Okay? So when you see a hemoglobin A2, you have that's 4.5%, something like that. You know that you have a problem with one of the beta genes. Okay. Now, yes, it could be S beta disease, but then you're going to see some hemoglobin S too. But you're going to have beta thalassemia, something wrong with one of those beta loci when you have an elevated hemoglobin A2. So really, to kind of wrap this up, I wanted to do a little side-by-side between iron deficiency anemia and thalassemia. So they're both going to have low MCV. They both can have normal RBC production, But if you see decreased RBC production, iron deficiency anemia. If that RBC number is less than 3, if it's, if it is 3, you need to be thinking iron deficiency anemia. Conversely, if you see a microcytic anemia with an increased number of RBCs, you need to think about thalassemia. Larger RDWs, crummy quality control in the factory, big RDW for iron deficiency anemia, a narrower RDW for thalassemia. The Menser index, I explained it down there. A couple days ago, it didn't work for me on a patient, but it's not meant to be definitive. The definitive test, how do you diagnose iron deficiency anemia? Ultimately, if you got to diagnose iron deficiency anemia, if you want to be 100% certain, and I think you should be 100% certain. I know the problem that real doctors, not subspecialists, run into is, do they send him to a lab or do you do a finger stick CBC in the office? And but if you want to know, you ought to check the ferritin for iron deficiency anemia. If you want to know for certain on a thalassemia, you're either going to get that answer from hemoglobin electrophoresis, too much A2 equals a beta problem, or if you really want to know for certain on alpha, you have to do gene testing. Okay? Otherwise, your alpha diagnosis ends up being one of elimination, and that's totally fine. Okay. So you got goat's milk, and this is what you see. The circled cell, an example of the circled cell is kind of brought out a little more clearly down below. Okay? So what is the cause of the abnormal finding? Okay. So this is going to be folic acid deficiency. So what production problem we're talking about now is another lack of raw material. And that is that, we're talking about lack of raw materials that lead you to get big, ugly cells. So folic acid is a dietary deficiency, can also be caused by some defects in absorption and some inborn errors of metabolism. It also can be caused by drugs. When I wear my oncology hat, and in particular when I treat leukemia, we basically are trying to create a little folic acid deficiency by using methotrexate. When you have a folic acid deficiency, the patient is not going to have neurologic symptoms as opposed to B12. They're going to have a macrocytic anemia with hypersegmented polys. They might have some neutropenia, and they might also have some thrombocytopenia. Management is, get them on folate and treat the cause, eliminate the goat's milk if that's the problem. B12 deficiency is very similar to folate deficiency. They both cause a macrocytic anemia. They both have neutrophil abnormalities, and when you diagnose these can be some pretty wacky counts. Some pretty profound anemia with macrocytosis, sometimes with white cell abnormalities or platelet abnormalities as well. What separates B12, as you all know from medical school, from folate is that it can be associated with neurologic symptoms, ataxia and paresthesias. You always want to check for B12 deficiency because if you treat the anemia with folate supplementation, the anemia will get better, but your neurologic symptoms will remain. Okay, I have seen B12 deficiency. Okay, I don't want you to think I've led too much of a sheltered life. Okay, 3-day-old infant. We kind of got it was a little bit tricky for me to organize this, and I've kind of muddled things up a little bit, and I want to clear that up for you. Is that we talk about, remember in the very beginning, I said production destruction, okay? But I kind of snuck the thalassemia, really a destruction problem in there. And it's a hard decision on where to put the thalassemia because I really like to put it up against iron deficiency anemia. So let's just take a breather and go back and say production. Okay, that's raw material problems. That's like iron, and that's like iron, and that's like your folate and your B12. Now let's shift gears and talk again about destruction problems, okay? So destruction problems can be inside the red cell, either the hemoglobin or enzymes. They can be the membrane, or they can be something acting on the red cell from outside. So let's use this question to get us thinking. This is a 3-day-old infant who presents to the emergency department with hypertonia, arching of the back, a high-pitched cry, lethargy. Lab results show that the bilirubin is 28.7. The family history is notable for the infant's father and uncle both having splenectomy for anemia. Okay, we're going to just take a quick pause. Every time I include this question, my heart breaks a little bit because I was a PGY2 and the bilirubin was really, I think 45, but I didn't put it in there because I didn't think you'd believe it. And I was in the NICU and the baby came for their exchange. So what does this baby have? What clinically does this baby have with the arching, the high-pitched cry, and lethargy? Kernicterus, yeah. Okay. And going to have an abnormal MRI to go along with that. So how did this baby get kernicterus? How did my baby that I really truly saw as a trainee get kernicterus? This baby had hereditary spherocytosis. And the reason, and I don't want to pass judgment or anything, but the reason it happened was a language barrier. So I just encourage you, don't, when you take on a patient that's outside your linguistic skills, do something to make sure that you get a good history. And the other thing that's important to remember, I think, is that I think those of you that have been in practice for a while, or even from your training and are recently in practice, will probably agree with me that some of your worst Billy babies, do you guys still call them that? Billy babies are patients with hereditary spherocytosis. So hereditary spherocytosis is a fascinating disorder. It's an autosomal dominant disorder. It's caused by defects in a variety of membrane proteins. The most common is ankyrin. Spectrin is right behind it. It can also be protein 4.2 and band 3 as well. And basically what happens is when you lose these proteins, the membrane structure just ain't quite right, and you lose some of the phospholipid bilayer, okay? And so the whole membrane is just not as good. It's a disease that has some very interesting lab findings, okay? Patients can have an increased MCHC. Who knows what MCHC stands for and who has ever looked at it? Okay, do not feel bad if you haven't raised your hand, because I think I had been in practice as a hematologist for several years before somebody reminded me of this, okay? So what you can think of it as is as you're shaving off pieces of membrane, okay? And what's happening is the cell, you're kind of cramming in a little more hemoglobin into that cell. And MCHC stands for mean corpuscular hemoglobin content, okay? And if you see a mean corpuscular hemoglobin content that is elevated, you should think hereditary spherocytosis. You can't eliminate hereditary spherocytosis if the MCHC isn't elevated, but if it's elevated, you need to be thinking this way, okay? All right. Osmotic fragility, fascinating test. Not specific at all, but it just means things are fragile. The test that we use a little more is eosin 5-malamide binding, and it's a flow-based assay, and basically what you're looking for is decreased expression of band 3. Because whenever any of these proteins whenever any of these proteins have a mutation, spectrin, ankyrin, protein 4.2, or band 3 itself, the cell loses band 3. And so that's actually the preferred tests of our hematopathologists now, in part because to do an osmotic fragility, they have to get a control, and it usually ends up being one of them, okay? I mean, so you want the hematologist to order a test where you're going to have to give blood, or do you want to order a test that's a little more specific and you don't have to give blood? You're going to have reticulocytosis, because is this a factory problem? Is this a production problem? No. You're having destruction, and so your factory kicks it into overdrive and makes more red cells. Management. Management here is really, I think, again, my focus has got to be to help you knock that dumb test out of the park. But it's hard not to talk about, I love taking care of these patients, okay? Like I said, like I told you in the beginning, I love what I do, and I'm really lucky to get to do it. But, I look at my slides and I'll say, when I took care of this kid, just a week ago, probably the most important management thing I did was education. And that was, when you have hereditary spherocytosis, you got to tell them, you got to teach them, what do you look out for? What does pallor look like? What are you looking for? What do yellow eyes mean? Can you feel for a spleen? Okay, so those are really important things. And so if you get into a hemolytic crisis, you want to make sure if the child gets into a hemolytic crisis, you want to make sure the family recognizes it and brings them in and, transfusion. If you're having enough problems requiring enough transfusions, the child's got chronic splenomegaly, just things aren't going well, then you need to think about splenectomy. And when you think about splenectomy, you create two issues. One, you have a patient without a spleen, so you need to think about antibiotic prophylaxis. And there's also some emerging data that with splenectomy in these patients, they'll get an increase in their platelet counts, and it'll place them at slightly higher risk for heart disease later in life. Very fascinating. So this is a really great slide of spherocytosis, and what are you seeing? Well, almost I should ask you what you're not seeing, and what you're not seeing is a lot of central pallor. Because remember, what does a normal red blood cell look like? It looks like, the biconcave disc. I always say it kind of looks like a donut, maybe without the hole all the way through it, a defective donut, that didn't get its hole punched all the way through it. And that's what gives you the central pallor. Well, if you don't have that biconcave disc, you're not going to see that central pallor. Okay. 4-year-old, previously a well boy of Middle Eastern descent, develops pallor, dark urine, and jaundice. He's taking Bactrim for otitis media. What is the most likely cause of his acute hemolytic crisis? So what's doing this to him? Does he have G6PD deficiency? Does he have autoimmune? Sickle cell disease? Did the drug directly attack his red cells? Or is this a guy with hereditary spherocytosis that we haven't diagnosed yet? Perfect. This is a classic example of G6PD deficiency, and this is one that I think, I think the only thing that could have made this more obvious is if we had thrown in some fava beans on the side. Well, he's taking his Bactrim, his trimethoprim sulfamethoxazole, and he's eating fava beans as he's taking it. So G6PD deficiency is seen in African Americans, Asians, people of Arabic descent, and Mediterranean populations. It can run the gamut from mild to severe. The hemolysis is these cells don't do well with oxidative stress, and it can be triggered by a variety of food, drugs, or even exposures. It can also be triggered by infections. I think the saddest one I have is a family that had a mothball exposure, and again, a child that ended up with kernicterus. And, it's just really disheartening. Really, on G6PD deficiency, we don't do much. We just try to keep you away from the exposure. These are patients, we might see once a year just for a little bit of teaching. Okay. 6-month-old girl, born in Nigeria, presents to the office with fever and irritability. Physical examination reveals a fussy infant who has anorexia, a temperature of 100, and swelling of all the fingers of the right hand. So what's the most likely cause of the symptoms? Now, I know this is not a great question when you're in the middle of the hematology lecture, but, do think about why I'm asking this, okay? Okay, so this is dactylitis. So this is a common first presentation of sickle cell disease. So sickle cell anemia is also a destruction problem, okay? And it's one where the beta globin gene has a mutation, and that mutation leads leads to polymerization of the hemoglobin, causing sickling, and gives red cells with a shortened survival. Normal red blood cell life, I think, is about 120 days, and with sickled cells, it's much shorter, and consequently, you're going to have an anemia. That anemia is going to tend to be a normocytic anemia with an increased reticulocyte count, potentially a little bit of thrombocytosis, and very frequently with leukocytosis. The peripheral smear will show sickle cells, polychromasia, some Howell-Jowl bodies. Your hemoglobin profile, like we've talked about, before, is going to show greater than 50% S, and it's going to show some fetal hemoglobin as well. Okay. Your profile is going to be FS, fetal hemoglobin, sickled hemoglobin. Okay. This is a great slide for showing what sickle cell anemia looks like. This, again, would be one of those pictures to circle and remember to know for the test, and hopefully, whether it's through medical school or your training, you've looked at this at least a little bit recently. Okay. So sickle cell anemia, hand-foot syndrome, that's the dactylitis, the swelling of hands and feet, vaso-occlusive crises that I'm sure you frequently took care of in your inpatient population. You manage those with hydration and pain medications. Acute chest syndrome. I think the thing that I'd really like you to recognize in acute chest syndrome are two things: that appropriate management for acute chest syndrome includes transfusion of some sort, either a simple transfusion or sometimes an exchange transfusion. It also necessitates the use of antibiotics. There is a classic New England Journal article on acute chest syndrome that I think every pediatrician should be exposed to in their training, that talks about causes of acute chest. The most common cause of acute chest is, we don't know, we don't figure it out. But the most common infectious cause, when we do identify one, is chlamydia pneumonia and mycoplasma pneumonia. So sometimes I like to teach my fellows and residents that acute chest syndrome is probably one of the few evidence-based indications for azithromycin, or one of the few times that we use azithromycin where we have data to back it up for. So acute chest syndrome should include both a cephalosporin antibiotic for encapsulated organisms and some type of treatment for atypicals. Sickle cell anemia, we can get splenic sequestration. We manage those with red blood cell transfusions. Typically, we transfuse a little less than you would normally, thinking maybe like 5 or 6 cc's per kg. The thought being that you're going to get an auto transfusion when red cells are released from the spleen. If you get enough splenic sequestration, we'll consider splenectomy. This is usually not an issue because typically in hemoglobin SS, we're going to have autoinfarction of the spleen and it's going to go away. Aplastic crisis, managed by red cell transfusion. What's the one infection we need to keep in mind for aplastic crises? Parvovirus. And so who's going to get an aplastic crisis? Is it just the patients with sickle cell? What about my patients with hereditary spherocytosis? Can they get in trouble? Oh yeah, you bet they can. It's anybody that depends on their reticulocytes to maintain their hemoglobin. So anybody that needs a reticulocytosis anybody that has a reticulocytosis at baseline is going to be at risk for aplastic crisis when they get an infection with a virus, most notably parvovirus B19. I think the most important thing, that we can do in caring for patients with sickle cell disease is keep them from having strokes. And the way we do that is with transcranial Doppler screening, and doing that screening is really important. Priapism is an important complication. Repeated priapism can lead to erectile dysfunction and infertility. We need to aggressively treat priapism with hydration, red cell transfusion. I hope that your urologists are moving more aggressively or partnering with you to do irrigation, because that can resolve things most quickly. Classically when we think about sickle cell disease, we talk about SS disease, but as you know, there is also hemoglobin SC disease. The biggest differences are those patients tend to keep a spleen and tend to have less symptoms. You can also have hemoglobin SD disease, and you can have sickle trait combined with beta thalassemia. If your beta thal mutation is one in which you make some beta chain, you're referred to as hemoglobin S beta plus, okay? And these patients will have a milder phenotype. If you're not making any beta chains, then you're going to be S beta 0, and essentially really the same phenotype as patients with SS disease. Okay. 13-year-old boy presents complaining of increased fatigue several days after a URI. Findings include pallor, scleral icterus, and a palpable spleen. Studies reveal anemia, an elevated retic count, some hyperbilirubinemia, and a big LDH. He had a normal CBC at his sports physical a year ago. So what test is going to be most beneficial? Where are you going to get your answer? Is it going to be from G6PD, Coombs, osmotic fragility, erythropoietin level, hemoglobin, or electrophoresis? Okay. Let's see your answers, because a couple answers are going to get you in trouble with me depending on what you say. Okay. Whoever answered EPO level, you're in trouble with me. And the reason I guess you're in trouble with me is I'm not sure I've ordered them that all often. I've done it kind of when I'm desperate and there's kidney function issues, but I don't think there's anything here that would lead me to. There are very few situations in which I would get led to do an EPO level. Osmotic fragility, I'm getting away from that, so that's not a favored test as well. I'm worried that the boards have not gotten away from that as much, so I don't want to be too hard on osmotic fragility. But what we're looking for here is a direct Coombs test, because what I think is important here is you've got a 13-year-old, right? So somebody who's been healthy, or the implication of the question, maybe it could have been spelled out a little better, has been healthy for his life and has this sudden onset of abnormalities. And these abnormalities scream hemolysis, right? Elevated retic, elevated bili, elevated LDH, that's destruction. So what is a sudden onset thing that could happen? Well, the sudden onset thing that can happen is autoimmune hemolytic anemia, okay? And this can often be preceded by a viral infection. You can get acute hemolysis. It can be very severe. Reticulocytosis, hyperbilirubinemia, and hemoglobinuria are common laboratory findings. You might see some mild splenomegaly. You'll have a positive Coombs test. This is a disease that's treated with steroids. And I want to emphasize that if need be, you treat this with transfusion. And you might say, well, you know, you're just adding fuel to the fire. Well, if the hemoglobin gets low enough, if you start getting that hemoglobin of 2 or 3, right? And this is not a process, it's not like iron deficiency anemia where it's happening slowly, 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 and the body's accommodating. That, you know, this becomes a life-threatening emergency. And this is the case in which we as hematologists will sign off on least incompatible blood, okay? The blood bank says, hey, you know, we can't match, you know, it's, you know, we're getting hemolysis on everything that we try for you. You say, fine, least incompatible, and at least we're gonna try to get that hemoglobin up a little bit, okay? You kind of end up jumping around a little bit, and I want you to make sure you're staying with me, and that is, you know, between production and destruction, okay? And I've kind of gone back to, I'm going to go back to production here. Let's go back to the idea that some kinds of abnormalities can be caused by production problems. 18-year-old Hispanic male, I remember meeting him. Fatigued for 3 weeks. His soccer coach was furious with him, said he wasn't hustling, wanted to know if he had started to take up smoking, and was just mad. This guy was not getting up and down the field. This is what his CBC showed, and hematology oncology performed a beautiful bone marrow biopsy that looked like that. Okay? All right, so what does that bone marrow biopsy show you, and what is the explanation of our patient's findings? Okay. Okay. Very good. That's severe aplastic anemia. That's an empty factory, okay? That's a factory that doesn't have any red cell precursors in it, doesn't have any white cell precursors in it. We'll go back just for a second. What are those white areas? Those are fat, okay? And so what you do when you look at a bone marrow is you estimate the cellularity. And the cellularity is the it's a goofy calculation. It's not even really a calculation. It's something you can only roughly estimate. You basically mentally add up all these areas where you see cells, and you add up all the areas where you see these white spots, which are globs of fat, and you guesstimate which percentages are which, okay? And so this is, you know, and some of this is stroma. It's not even really red cell precursors. So this is a cellularity of about 5 to 10%. You know, this is something that's very hypocellular. How cellular should a marrow be? Roughly 100 minus your age. So this is an 18-year-old. You ought to see about 80% of that be purple stuff and not these big white fat areas, okay? All right, okay. So, you know, marrow failure. This is when the factory goes on strike, or, you know, basically everybody who was making white cells, red cells, and platelets has left the building, and what results is pancytopenia, sometimes called aplastic, and, you know, also called aplastic anemia. And aplastic anemia can be broken into two categories: acquired aplastic anemia and inherited syndromes. You can also have some failures, some pure red cell aplasias when the factory kind of stops making red cells. And the two that you want to be able to distinguish are Diamond-Blackfan anemia and TEC, transient erythroblastemia of childhood. Okay. So severe aplastic anemia, that means everything's down. That means you have less than 25% of the normal cellularity. That means, or you have less than 50% of the normal cellularity, and you have a low ANC, a low platelet count, and a low absolute reticulocyte count. Again, the way I look at it is it's empty, okay? You get a nice, beautiful bone marrow biopsy, and when you take it out, that biopsy looks pale, and then when you look at it under the microscope, all you see is those globs of fat. Anytime the marrow is stressed, the MCV tends to be a little bit higher, and the hemoglobin F will also be higher. So I like I said, I see probably 50 microcytic anemias for every macrocytic anemia I see, and they cause me significantly less heartburn. Macrocytic anemia always makes me worry about bad things. So acquired versus inherited severe aplastic anemia, most times we don't know what causes acquired severe aplastic anemia. It's because because it's idiopathic, which means your doctor is a pathetic idiot. Your hematologist is a pathetic idiot. A classic, I think, thing to know about is that severe aplastic anemia can show up post-hepatitis. I've seen this several times in my career. One time in my career, I saw it show up with fulminant hepatitis and aplastic anemia. If that's the case, the cure for the aplastic anemia is to transplant the liver, okay, to get a new liver in there. It can be post-viral infection. Sometimes those can go away. And another classic teaching that fortunately we don't see very much is drug and toxin exposure. More commonly in children, severe aplastic anemia, or important to think about in children, is that it can be part of a syndrome, Fanconi anemia, dyskeratosis congenita, Shwachman-Diamond syndrome, or congenital amegakaryocytic thrombocytopenia. Fanconi anemia, I think this is a tough one. It can be autosomal recessive, it can be X-linked. There are many, many Fanconi genes, and they're big, and they can have many different mutations. The classic things to know about Fanconi are these patients have abnormalities that you need to look for. They have short stature, hypopigmented lesions, cafe au lait spots. They can have abnormalities of the thumb. They can have small heads, hypogonadism, and they can be developmentally delayed. Macrocytic anemia, they can present initially with thrombocytopenia as well. And the challenge of this is that you can cure them with their inherited aplastic anemia, but they're still at risk for other cancers. The teaching here is that sometimes we can get away with using androgens, but I really think these are patients that ultimately benefit from a bone marrow transplant. Dyskeratosis congenita is a fascinating disease. Fascinating disease. Do you guys remember what telomeres are? Those are the kind of the junk ends of the DNA. Remember, as you replicate, you have the leading and lagging strand, and as you lose a little bit off the top on as you divide, so you have these junk ends, these telomeres at the ends that, as with divisions, get shorter and shorter. Well, patients who have short telomeres, or in dyskeratosis congenita, is a condition in which patients have short telomeres, and these patients have an increased cancer risk. They also have some very interesting physical findings. Classically, patients will have very, very, very funny-looking nails and some leukoplakia, and often kind of really abnormal dentition, like the kind of triangulated teeth. Shwachman-Diamond is a disease that can present with aplastic anemia, but it's one that also kind of classically will present with pancreatic insufficiency and steatorrhea. Amegakaryocytic thrombocytopenia is something that presents early in life and on bone marrow has absence of megakaryocytes, the really, really big cells that make your platelets. DBA versus tech. I have to say I hate tech. I don't know. I just do. And I hate, this is to me a challenging sometimes decision to make. So Diamond Black fan, less than a year old, short stature, other anomalies. Kind of the definitive test is erythrocyte adenosine deaminase, and we can treat it with steroids, transfusions, or BMT. I hate tech because it's, what is it? I still don't really understand. And how does it differ from really bad viral suppression? I don't know. And how do I diagnose it? I just wait it out. So, but I still think, unfortunately, I think the board still think of it as a very important topic. So, if you got this well kid who doesn't fit into any other categories of anemia, think tech, okay? You don't have any dysmorphia, you have a normocytic EMA, think tech on your questions, okay? All right, white cell disorders. I think this for me is a tough one. I like to focus my teaching on, for white cell disorders, I like to focus it on morphology and pictures, because I think a lot of what the function problems are things that now are for you going to be taught here in immunology, and in clinical practice I think belong sometimes a little better with the immunologists. So morphology problems will cover toxic granulation, Pelger-Hewitt anomaly, hypersegmentation, look at some funny looking lymphocytes. I'll leave the immunologist to talk about function, and then we're going to talk about number. Okay, white cell morphology. You can see toxic granulation, Dolly bodies, which are, I think, sometimes an interesting question to ask on a board. What do they come from? They come from agglutinated ribosomes, and you can see these with inflammation. You can see a left shift. You guys need to know what a left shift might look like in a picture, and you should also look at what a Pelger-Hewitt anomaly is. This is toxic granulation. There's nothing wrong with it. It just means the patient's sick. These are Dolly bodies, okay? And probably if you see one of these, the question you might need to prepare yourself to answer is, these are aggregates of what? Cell membrane, DNA. The answer will be ribosomes, okay? Toxic changes in left shifts. What you're seeing here is that sometimes when the body's responding to stress and it's sick, it just decides, I'm going to throw everything out that's in the marrow, okay? And so when you see a marrow that looks like this, again, it doesn't necessarily represent a marrow problem. It just represents a patient who's sick. Pelger-Hewitt anomaly means you just don't have enough lobes, so 2 lobes, okay? Just like we talked about hypersegmented neutrophils in B12 and folate deficiency, Pelger-Hewitts mean you're the opposite, hyposegmented, and there's really not much of a problem associated with these at all. Stadmeisters are 1 lobe. And you can tell them apart from monocytes because of how they look and because of their granules, but I don't think that's something you'll be asked to do. 11-year-old girl, fever, sore throat, enlarged cervical lymph nodes. Her peripheral smear is shown here, and when I cover leukemia in the next hour, you will know what's different, okay? So I think I just gave away the answer, okay? But what is this most likely diagnosis? Those of you who answer leukemia are going to be doing it just to torment me, okay? All right, tormentors. Okay, wise guys. That is not leukemia. Okay, we are going to cover a leukemic blast in the oncology part of the talk. But leukemic blasts are known for being big and having no cytoplasm. Those cells that we saw had lots of cytoplasm. And those are what are called reactive lymphocytes. And then those are classically what you're going to see in viral infections, very, very typically in infectious mononucleosis. But there are other things that can cause reactive lymphocytosis besides mono, the other monoviruses, other viruses including HIV and just about anything else, including maybe phases of the moon. You can get them in pertussis, you can get them in some protozoa infections, you can sometimes see them in autoimmune, and you'll apparently, though I've read this, but to be honest, I've never kind of seen this in a correlated way, seen it in stress and with cigarette smokers. Okay. This is a great question, because I think of so many patients that I have that are like this. It's not an overwhelming number, but this is a neat question, okay? Since 8 months of age, 13-month-old boy, low white count, low neutrophil count. His hematologist decided, I really want to do a bone marrow aspirate, and he's got low granulocytes, but he's got normal trilineage precursors. He just doesn't have that last mature cells hanging out as much. So what's the pathophysiology behind this condition? And let's throw one more thing in. This kid came to you because he had a CBC drawn on a routine basis. Instead of just checking the H&H, they checked a CBC when they were worried about checking for anemia, and they found it. And he really hasn't had a serious infection. He's had the sniffles and maybe an ear infection, but he's done well. So what is causing his leukopenia and neutropenia? Okay. So most of you guys got this, okay? And what I want to emphasize as I talk about this is chronic benign neutropenia, also known as autoimmune neutropenia. It's the most common cause of neutropenia in healthy children. When we compare chronic benign neutropenia to not benign neutropenia, you're gonna know that. Sorry, I got my tongue a little tied. Let me just use an example. Okay, the congenital neutropenias that are not benign, okay, like Kostman syndrome, which we're going to talk about in a slide. Those kids show up sick as hell. I haven't seen very many in my life. The last one I saw had horrible pseudomonal cellulitis. Just every serious infection. Just a terrible course until we were finally able to get him to transplant. Chronic benign neutropenia is the kiddo who basically, you just find this because they have some normal routine infection, or you drew a CBC. Okay. Median age of onset, sometime 8 to 11 months of age, typically in 3 to 38 months is when you might see it. You're going to see ANCs below 500. It's going to last around 2 years. Most kids resolve it by 3 years of age, but obviously you can go on a little longer, especially if you got it a little later. You can send out an anti-neutrophil or anti-granulocyte antibody, not an ANA. That's anti-nuclear antibodies, right? So you send anti-granulocyte antibodies. It is usually positive, but it is not a perfect test. You can have chronic benign neutropenia and not have that positive antibody test. The bone marrow exam, that is, I meant to say maturation arrest. The earlier stages are okay. Maturation happens normally, and you don't see the very mature cells. So you're seeing normal trilineage hematopoiesis. Management, you treat infections, counsel parents. Very, very rare circumstances do you use GCSF. And again, this is all about reassurance, teaching them that, hey, this is going to go away, and this is not a big deal. Somebody asked me just a fabulous question, and that is the idea of ethnic neutropenia. And it's a consultation I see very often I see it all the time. And It is completely normal for healthy African Americans to have lower white blood cell counts and lower neutrophil counts. I think there are 2 points that you need to understand is that norms on lab tests are statistical norms, right? You take a bunch of healthy volunteers, you see what they have, and you create that a norm, okay? So sometimes being outside that norm, it's something you need to think about, but it doesn't necessarily indicate a disease state. We could compare it to height, right? Maybe I'm outside the norm for height. I don't know, or I'm close. Certainly I have one colleague who is, but he's an MD, PhD, smartest guy in our group, has a wonderful family. He's normal. I'd love to be as normal as him, but he's not. By height, his value falls outside that range. And then if you think about height in terms of ethnic groups, there are some ethnic groups that are taller, some that are shorter. Same holds true for other tests, including white cell counts and ANCs. So if you see a question or a patient who's an African American who has a white count of 3.5, I saw a wonderful young man whose family had come from Kenya, had a white count of 3.5 and an ANC of 1,000. I asked him how many days of school he had missed last year, and the answer was 0. How many times he'd been in the hospital? 0. And, he had this done on a routine CBC, and they wanted to come find out what I thought about it. And I said, it's who you are, and I pulled up some references that are appropriately race-based norms. And for his age, the lower end of normal for ANC is 1,000. And the lower end of WBC, I think, is 3.3 or 3.2. So just a really a simple but interesting and important concept. The things that are not benign neutropenia can be cyclic neutropenia, and that has a defective maturation. Those patients will have stomatitis, lymphadenitis, and can have severe infections in about 10% of the cases. The really not benign neutropenias are what are classically called Kosman syndrome, and they're caused by mutations in the ELA2 or HAX genes. These patients will have neutrophil counts less than 200. You'll need to treat them with GCSF. This is something that can transform into MDS and AML, and they get bad infections. This is not benign. These are sick kids. Schwachman diamond, can show up again. We put it in the aplastic anemias. It can show up with anemia. It can show up with neutropenia. It can show up with thrombocytopenia. But it's going to be accompanied by failure to thrive and pancreatic insufficiency. Okay. During a routine screening, CBC, a 1-year-old is noted to have an abnormal differential. The smear is prepared for your review. Okay, so what do we got going on here? Okay, all right. So what were those cells that we were seeing, and what are they associated with? Okay. Things looked very red. Okay, correct. So you saw a lot of eosinophils. That's something that you should, sometimes they're even a little brighter red than showed up there, but they're going to have a whole lot of granules in them, and they're going to be red. Okay, and we can see eosinophilia with allergic disorders, though that's not usually an impressive eosinophilia. You can see it with atopic dermatitis and other conditions. But if you're going to get an impressive eosinophilia, it's typically going to be associated with parasites. You can see it sometimes with malignancy, but usually the symptoms of malignancy kind of jump out and smack you. You can see it with hypereosinophilic syndromes, which I don't completely understand. And I need to usually get the help from my immunologists on them. And it can be seen in some immunodeficiencies as well. Hopefully you can hang in there with me on some bleeding and clotting. And this is where I've added a few new things to the talk. And so I'm hoping I'm hoping that I'm going to help you. Hemostasis, two-part process. Primary hemostasis, secondary hemostasis. Primary hemostasis involves platelets, von Willebrand's factor to grab onto those platelets, and a bunch of subendothelial proteins, okay? The von Willebrand's factor is going to link the, it's going to be, I've seen it described as like being the hook on the hook line on an aircraft carrier. You get a plane coming in, right, on an aircraft carrier. Think of the plane like the platelet, and the von Willebrand's factor helps hook the platelet or grab it to help it link to the subendothelial proteins at the site of damage. Okay. So what is primary hemostasis? Platelets have to adhere to the damage. They have to become activated and recruit additional platelets to the injured site. And then we get fibrinogen, which forms links, that forms bridges between the activated platelets and forms a plug. So when I'm sitting in the office and explaining this to a patient, I'll usually have them put their fists out and say, okay, bleeding is either a two-part process. It's primary and secondary. The first part is your platelets, your fists have to come together and make a plug. So that's primary hemostasis. Secondary hemostasis, I say, is okay, you got this plug, but you need to firm that plug up. And that's what happens when you get all these proteins coming in behind. And I'll say, hey, that's where all the numbered proteins come in behind, and they help stabilize that primary platelet plug. Okay, first time I've tried this. I'm excited. You can give me feedback on it. This is called Coagulation Made Easy. My colleague on the adult side, Alice Ma at North Carolina, is the genius behind teaching this. And I actually think the UNC med students know the coagulation pathway as well as anybody. So we're going to try it, okay? We got the PTT pathway, the PT pathway, okay? And where they meet is where X marks the spot, okay? And inside that little X is where we can, inside that little X, they meet at X where it marks the spot. X wears a little hat on top of its head, okay? And that's factor 5. All right? So you have the PTT pathway, the PT pathway coming together at X marking the spot, and then you have the common pathway that's nice and simple, that's 2 in 1, your prothrombin and your fibrinogen. Okay? So a little more complicated diagram, okay? We have the PT pathway, the extrinsic pathway, which starts with tissue injury. We have the extrinsic pathway, with tissue factor and 7A. Then you have the intrinsic pathway that gets that kind of marches through all those factors that you never know how to keep them in line, and goes to 10 where the hat is, and into the common pathway of prothrombin and fibrinogen. This is a good one to kind of keep in your back, because what it'll show you things here that are pro-clot making in green and red anti-clot making. Okay? But let's go back to the simple Carolina way of thinking about coagulation. And so how do you know the PT pathway? The PT has one less letter than PTT, so that's the short pathway. PT values are shorter than PT values because the pathway is shorter. Because the PT pathway is shorter, that means there are fewer steps to remember. Okay, PT shorter than PTT, fewer steps. This is lucky. So what do you think of? Lucky number 7, okay? So the PT or extrinsic pathway uses tissue factor and factor 7 to get to X marks the spot. Okay. The intrinsic pathway is the longer pathway. It's the PTT pathway. And learning the intrinsic pathway is a basic tenet of hematology. So why is it a basic tenet of hematology? Well, it's a basic tenet of hematology because it involves factor 12, 11, 9, 8, and then 10. Okay? So, I don't know. I hope that helps a little bit. Okay. So why did I take the time and why do I take the effort of splitting bleeding into to primary and secondary hemostasis? Well, they present differently. And so depending on the clinical scenario, you can read a clinical scenario and say, oh yeah, this has got to be a primary hemostatic problem. So that means I need to think about platelets, I need to think about von Willebrand factor, and that's where the answer is going to be. If it's a clinical scenario that says, well, that doesn't sound, this is definitely secondary hemostasis, this is definitely a problem with the plug not being solidified, then you're going to think about, well, do we have a factor problem? Okay, so platelet disorders and primary hemostasis show up with spontaneous bleeds, nosebleeds, gum bleeds, hematuria. Factor problems or disorders of secondary hemostasis are classically hemarthrosis. Sorry about that. There can be a little overlap. Okay, bleeding gums, I don't know what that's going to be, but it could tend to favor primary, but have I seen hemophilia patients bleed? Oh yeah, do I want the dentist to do things with them without me, knowing about it? No, I don't. So there is a little bit of overlap, but if you've got hemarthrosis, if you've got a big joint, or a muscle bleed, that's going to be a factor problem. And you may be thinking, well, come on, those are, they're all going to show up really early. You're going to know, you guys will have a family history. You'll be taking care of dad, and you'll know how to find that hemophilia patient. The answer is no. I had a patient who didn't know he had mild hemophilia until he presented after injuring himself playing basketball with a massive muscle bleed, and we found his factor VIII level was about 11%. So it is not out of the realm of possibility that a general pediatrician is going to meet someone with hemophilia at a little older age in life. Okay, and one thing to think about when we think about clinical scenarios is bad menorrhagia with first menses is kind of a classic von Willebrand scenario. Okay, so this is a good table just to kind of think about what are those clinical characteristics that we should think of with primary hemostasis versus secondary hemostasis. Okay, and this is kind of how we think. Okay, all right. 2 weeks after a viral syndrome, a 3-year-old child develops bruising, petechiae all over the place, and gum bleeding. On exam, he doesn't have any hepatosplenomegaly or lymph node enlargement. His laboratory testing shows a normal hemoglobin, a white blood count, and a normal differential. His peripheral smear is shown. Okay, think back for a second. What did the peripheral smear look like on the patient who had iron deficiency anemia? So sometimes when you look at something, not only do you need to think about what you're looking, what's being shown, but also think about what's not being shown. So what does this patient have? Leukemia, severe aplastic anemia, TTP, ITP, or hemophilia A? Okay, well, this is a problem of primary hemostasis, right? Because we said lots of petechiae. That's what that table told us, okay? And what wasn't there, okay? What wasn't there was platelets, okay? I see some of you marked TTP. That's super rare, but I'm going to show you that just for fun. So the first, I said, okay, the first thing you do in primary hemostasis is your platelets come together and make a plug, okay? How do you make a plug if you don't have any platelets, right? So that's the first thing we have to check for when we're working someone up for primary hemostasis is do they have platelets? And ITP is a common disease of no platelets. ITP stands for immune-mediated thrombocytopenia. Sometimes we used to call it immune thrombocytopenia purpura. Sometimes we call it, what was it called? Idiopathic thrombocytopenia purpura. I just think of it as immune thrombocytopenia, okay? It's a destruction of antibody-coated platelets. The body goes a little wacky, makes some antibodies to fight off the virus, but those antibodies also attack the platelets. These children, as opposed to a child with leukemia, look good. I should have included in that little vignette that the child had destroyed your waiting room, okay, and was climbing over the exam table trying to, grab the otoscope hanging from the wall, okay? That's not what a patient with leukemia looks like, but that is what a patient with ITP can look like. Isolated thrombocytopenia can have some normal or large platelets. There was a large platelet in the center of that screen, okay? But there weren't nearly enough. It's typically a diagnosis of exclusion. They do not need a bone marrow aspirate. It's not necessary if it's typical. If there's some other abnormal findings, you can wait. You can treat this with steroids, IVIG. Just like I told you with autoimmune hemolytic anemia, in autoimmune hemolytic anemia, if you're dying, give me blood. If I've got autoimmune hemolytic anemia and I got a hemoglobin of 2, I want you to give me blood before my heart gives out, okay? The same thing holds true in ITP. Yes, you don't transfuse platelets if you're not having serious bleeding, but if you've got a head bleed in ITP, you're going to do everything. You're going to give steroids, you're going to give IVIG, and you're going to give platelets, okay? All right. The other thing you can treat ITP with is what? Time, okay? A tincture of time. You don't have to do anything. If the patient is not bleeding, you don't have to treat them, okay? We say you don't treat by the numbers. Most everybody will treat for less than 10,000. But, platelet counts above 10,000, no bleeding, no wet purpura, I'm going to sit tight. This is a neat question, probably not all that helpful. 16-year-old girl, Mediterranean descent, presents to the emergency room with bruising and yellow eyes, significant labs, anemia, thrombocytopenia, LDH through the roof, indirect bilirubinemia, reticulocyte count. Which of the following is not true about her condition? Okay, maybe this isn't as great a question, because I think the cooler thing about this is actually looking at the smear. So schistocytes will be present on the peripheral smear. Life-threatening, must be treated with plasmapheresis and steroids. Underlying pathophysiology is Adams TS13. Underlying pathophysiology is autoantibodies against platelets. Okay. All right. Autoantibodies against platelets is ITP. So since this is one of those negative questions, which for the people who follow you, I will try to get rid of another negative question, this is not ITP. Okay. So this is actually TTP. And TTP is thrombotic microangiopathic hemolytic anemia. Before we had you get thrombocytopenia, microangiopathic hemolytic anemia. Remember, that child was anemic, so they're going to have more than ITP. They can have neurologic dysfunction, they can have renal dysfunction, and they'll often have fever. So I think I'll make a mental note for the group that comes next from you that I'll move this picture up into the question and maybe rewrite my answers, because what gives away TTP is all these darn schistocytes, all these cells that look like they've been kind of torn up or broken apart. And they look that way because they have been torn up or broken apart. They've been torn up or broken apart as they go through, as they go through these little vessels that have little microthrombi in them, and you're getting, that type of hemolysis. Okay. All right. It's an interesting disease. It can happen congenitally, and when you don't have any Adams TS13, or it can happen when you get an antibody against TS13, and that all of a sudden just goes down. And Adam TS13 is responsible for the breakdown of really big von Willebrand multimers. And really von Willebrand multimers are like uber coagulation crazy happening, okay? And if you have these uber ultra large von Willebrand multiples hanging around, you're going to get microvascular thrombi, and that's going to mess everything up. And you're going to get multi-organ dysfunction, potentially including, getting little thrombi in the cardiac vessels, which can lead to arrhythmia and death. Okay. 4-year-old boy, history of severe snoring, develops life-threatening bleeding following elective tonsillectomy. CBC shows a platelet count of 115,000, an MPV of 16.5. MPV, what's that? Oh, mean platelet volume, right? PT 11.5, PTT 35.5, fibrinogen 640. Okay, so what of those numbers are abnormal? Platelet count, a little bit. Would that have caused them to bleed? Man, I don't think so. MPV 16.5, that's a little normal, but does platelet size cause you to bleed? I don't know. But there's some clues there, and what the PT, that looks pretty normal to me. PTT, fibrinogen, that all looks good. So what is the pathophysiology underlying this guy? He's got a little bit of thrombocytopenia, and he's got some big old platelets. So what disease is this? This is absence of glycoprotein 1b, or this is what's known as Bernard-Soulier syndrome, characterized by big platelets. What you can think of is, remember, I said your platelet you can think of as like the airplane trying to land on the aircraft carrier. And I said the von Willebrand factor was like the hook line, right? 1b is the protein that is the hook on the airplane. Does that make sense? So your platelets don't want to stick to where the action is, okay? And so you got enough of them, but they just don't do their job. So this is, Bernard-Soulier is what we call a qualitative platelet disorder. It is autosomal recessive, and we have a huge bleeding disorders center in North Carolina, and we have just a handful of Bernard-Soulier syndrome patients. I think originally, if you kind of trace its origin, it's associated with French Canadians. So maybe those of you who either trained in Canada or in New York have maybe seen this more, but I haven't seen it. Glanzmann is kind of a cousin to Bernard-Soulier, and that's an abnormality in a different platelet receptor, and these platelets don't bind fibrogen and they don't aggregate as well. And then there are the May-Heglin-related platelet disorders. Okay, I don't think you'll see an aggregometry plot. Okay, blue is the control, red is the affected patient, but this is pretty cool. If you see it, you're going to knock it out of the park. Okay, what's happening is that the way this goes is that you basically form a clot, okay, and everything clots and falls down when you add these agents, okay. If you're the normal control, they go boop, okay, and the optical density, which is kind of the opposite of your ability to shine light through, goes, is fine. You can, you form your clump, boop, form the clump, okay. In Glanzmann, your patient doesn't form. If you put ADP in, the platelets don't get revved up and they don't clump. If you put epinephrine in, they don't clump. If you put collagen in, they don't clump. But if they put ristocetin in, they clump a little bit. Okay. In Bernard-Soulier, they clump with ADP, they clump with adrenaline, they clump with collagen. They don't clump with ristocetin. 2-year-old child in septic shock in the ICU, multiple blanching purple lesions, oozing. Come on, this is like the classic oozing of the IV site. So what do they have? They're septic. Come on, what do they have? They got DIC. So which of these statements is true about DIC? D-dimers are going to be elevated, platelet count going to be normal, fibrinogen elevated, factor VIII elevated, PTT will be normal. Okay. All right, cool. So D-dimers are going to be elevated. Man, when you're in DIC, you just chew everything up. Thrombocytopenia, platelets are getting consumed like crazy. Fibrinogen, getting consumed like crazy. Factors, getting consumed like crazy. PTT, well, everything's, getting consumed. Your clotting isn't going to be very good, so your PTT is going to be very prolonged. So DIC is characterized by both bleeding and clotting. Its management is treat the underlying disorder. Decreased platelets, prolonged PTT, decreased fibrinogen, elevated D-dimers and fibrin split products. I don't know, we don't measure fibrin split products very much anymore. Decreased clotting factors. Again, clotting and bleeding and clotting all revved up, everything getting consumed. Okay. 1-week-old male infant presents to the emergency department with continuous oozing from a circumcision. Hemoglobin shows bleeding from the circumcision, and the remainder of the CBC is normal. Okay. So what do you want to do next? Okay. Yeah, and that's a tough question. I was, again, when I was prepping, I was thinking, I can see where, I can see where this is a tough question, but I'm going to give you, the reason I went with this is I want to give you a lesson, and we'll come back to it in oncology, is that I think an important test-taking strategy is to order the Willie-Sutton test. Okay? Thinking, what the heck did I just say? Willie Sutton was a bank robber, and people asked him, why do you rob banks? Does everybody know what his answer was? It's where the money is. So I think you should answer questions on an exam using the Willie Sutton rule. And so because often you'll see things like, I'd like to do that. Yeah, an ESR, that would be great. Oh yeah, I'll do that, whatever. But pick the answer that's going to give you the diagnosis. And oozing following a surgery, secondary hemostasis, is a classic. Oozing, delayed oozing, is kind of a classic late finding, secondary problem, and let's make the diagnosis of hemophilia. Okay. Hemophilia is most commonly a deficiency in clotting factor VIII, that's hemophilia A, but it can also be a deficiency in clotting factor 9 or 11, A, B, and C. Hemophilia patients can have mild hemophilia, moderate hemophilia, or severe hemophilia. Severe hemophilia means you basically have no factor. They can have post-circumcision bleeding, classic. They can have epistaxis. Again, I know I said it's a primary, but they can have that as well. Classically soft tissue bleeding, muscle hematoma, hemarthrosis, post-traumatic surgical bleeding, classically a little bit delayed, but that's it. And they can have intracranial bleeding. They will have prolonged PTTs, but what's going to make your diagnosis is the factor level. This is fascinating. There's all kinds of really cool stuff going on in hemophilia these days. For factor replacement, you need to give them factor, you need to educate them, you need to prevent injury, and you absolutely positively need to use prophylaxis, okay? Every patient with hemophilia deserves prophylaxis. It improves quality of life, it prevents long-term complications. They need to be on some prophylactic factor. 12-year-old girl presents to the emergency department with pallor and fatigue. She just reached menarche and has had bleeding for 8 days. Her hemoglobin is 6.7. Other counts are normal. What's going to be true? Does she have hemophilia? Is her INR going to be totally out of whack? Lupus anticoagulant, von Willebrand, antiplatelet antibody testing. Okay. Okay. This, I want you to burn in your brain, is a classic for von Willebrand disease. Okay. And this is how we will diagnose many a patient with von Willebrand's. Okay. Von Willebrand's, there are many different subtypes of von Willebrand's disease, but I think what a good general pediatrician needs to understand is type 1, and that's where we have basically, it's a quantitative disorder where we have decreased levels of von Willebrand factor. This can be treated with desmopressin to basically just kind of tell your body to throw out more factor. You can also have qualitative effects in von Willebrand factor, and you can have absence of multimers. Remember, I said too many multimers is TTP, and that's a bad disease. Infant hematology, just a couple of quick things. Term infant, delivered at home, blood in the stool, on exam, no petechiae, purpura, hepatosplenomegaly, or neurologic abnormalities. What is the most likely diagnosis? What is delivered at home a code word for in tests? Yeah, it's a code word for not getting something. Yeah, and I have no problem with home birth, and maybe to be honest, we ought to change the question, but classically in all my lifetime, that's been the code word for not getting for not getting vitamin K. Okay. And vitamin K deficiency leads to a decrease in the vitamin K dependent factors. How would you like to remember the vitamin K dependent factors? 1972, a year that most of you were not born in. All of you were probably not born in. I was born, okay? Actually, I was born before then, but 1972, 2, 7, 9, and 10. So 9 and 10, 1972, okay? Hemorrhagic disease of the newborn, you can get this from malabsorption. Patients with cystic fibrosis will have vitamin K deficiency and a typically mild increase in their PT. Lab features prolonged PT more prolonged than PTT, okay? If you see that PT is up a good bit and that PTT is only a little bit prolonged, I want you to think of vitamin K.